Title of my talk I have given: A Journey Through the Metamorphosis of Management of Primary Congenital Glaucoma in India, 3 Decades of Experience. So I have had the opportunity of observing the revolutionary changes that has taken place in the surgical management of glaucoma over the last 3 decades. Primary congenital glaucoma is basically a surgical disease, and surgery should be performed at an early age as possible. Youngest child I have operated is at third day of birth, and within a week we have done several hundred. The options are many, as we presented in the form of a slide. I'll come to it again, but the question comes, what is the best primary surgical option? The options written here are goniotomy, which is the first surgical procedure invented by Otto Barkan. Then the alternative technique, trabeculotomy ab externo, primary trabeculectomy, and combined primary trabeculotomy is the most important surgical option available for us in Indian patient population. Why? I'll come to it later on. In 1995, with the help of Prolin Suture, Alan Beck and Mary Lynch described the technique of 360-degree trabeculotomy, which has been refined of late with the help of fiber optic illuminated microcatheter. And this is the primary surgical technique in the Western population now. We'll come to it later on. Endoscopic goniotomy, which was tried, but not many people try now because of obvious reason, cost involvement and the visibility problem. Goniotomy assisted transluminal trabeculotomy, again an ab interno technique, the 360-degree trabeculotomy done ab interno. If we, this 9th consensus survey World Glaucoma Association conducted, it is known that only 14% of the experts all over the world perform combined trabeculotomy, of which 41% use intraoperative mitomycin. Why this small percentage? Because in Western population, in some other geographical areas, definitely, particularly the Caucasian and the European patient population, congenital glaucoma will present with megalocornea, but the corneal clarity may be such one can afford to do ab interno approach in the form of goniotomy, or now ab interno trabeculotomy. The type of patients we see in India are relatively more severe, moderate to severe form of the disease, in which goniotomy is just not possible, probably about 70% or over percentage of patients, and external trabeculotomy alone gives relatively poorer result, and that's the reason combined primary trabeculotomy and trabeculectomy. We learned this technique from Professor N.N. Sood of All India Institute of Medical Sciences, with whom I did my senior residency, and I learned the technique from him. The video we showed belongs to this patient here seen. Both the parents were having congenital glaucoma, operated, and both the eyes of both the patients were having no light perception. Here is a love story. The man, both the father and the mother of the child was not known to each other. There was no consanguineous marriage. The man operated for congenital glaucoma. Ultimate result is blindness. He was a good singer. He used to teach singing. The lady also had the same fate about the eye problem, wanted to learn music from the man. At first, not at first sight, at first hearing of the song, the lady fell in love with this man, and the child here, premature child, operated and did very well. The child, I just completed the 11 month of follow-up of that child. The bleb appearance of the 6 weeks post-operative appearance is seen here. It's a very interesting learning experience for me. The question is, when you depend on Slem's canal for the surgery, you'll have to see really Slem's canal is usually or anatomically formed or not. in extreme degree of maldevelopment or congenital abnormality. Sometimes there may be maldevelopment of the Schlemm's canal. There you may have to do trabeculectomy or other technique. Now onwards, in 10 different situations, I will explain some clinical situations which we encountered. The video you see here was surgery performed on a 6-month-old child with congenital glaucoma. Schlemm's canal was identified properly, but when we did the trabeculotomy on the second side, there was severe intracameral bleeding, as you can see here. This bleeding was probably because of bleeding from the major arterial circle situated in the ciliary body actually. Although called arterial, it is in the ciliary body. What we did, we stopped for a while, allowed the blood to clot over the iris surface, and then with the help of irrigating an aspiration cannula, Simcoe's cannula was used to remove the blood clot from the anterior chamber. The question is, there may be recurrent bleeding or continued bleeding. Fortunately for this situation, it not happened. After the removal of the clot, we continued the surgery and the wound was closed. You can see at the end of removal of the clot, it appeared nothing happened. And here is the postoperative appearance of the patient. Patient is doing very well, completed about 15 years of follow-up. So bleeding intraoperatively is almost invariable, be it goniotomy, be it trabeculotomy, be it combined trabeculotomy, trabeculectomy, any approach. The question is, it is self-limiting. Sometimes it stops spontaneously. This kind of severe bleeding I encountered twice in my 30 years of experience. All that is required is maintain your cool, wait, if necessary, give a small air bubble in the anterior chamber to create tamponade so that the bleeding stops, and ultimately retraction of the vessel wall or the arterial wall stops the bleeding automatically. A clinical situation here is sudden corneal clouding in a child where there may be only megalocornea or beautiful eye to start with. Parents usually feel that the child is having beautiful eye. Actually, it is megalocornea, a manifestation of the disease in early childhood. This patient presented to me at the age of 3 months when left eye developed sudden corneal clouding because of acute eye drops. We operated, and the lower panel photograph shows how dramatically this photograph was taken 10 days after the surgery. Corneal edema cleared, and you can see the Habs dry. This is a series we published, a large series in the world literature. If we look into the presentation of acute eye drops, there are not much publication on this series. We published, Susmita published from PGI. Very interesting thing. When the patient is presenting with sudden corneal clouding, that means at that point of time, the pressure of the eye exceeds the breaking point of the Young's modulus of Descemet's membrane. Descemet's tear happens, and the water percolates, aqueous percolates into the stroma, corneal stroma, creating sudden corneal clouding. This is an emergency. What happens? So when acute eye drop happens, it reduces the pressure automatically, and there may be little corneal clearing. That doesn't mean that you can afford to leave it like that. You'll have to operate so that there will be permanent control of intraocular pressure or long-term control of intraocular pressure. A clinical situation here is seen. In all patients, corneal edema will not clear, even when the intraocular pressure control is achieved. Here is a situation, patient operated at the age of 2 weeks, and we realized that the corneal edema will never clear totally. We will have to do corneal transplantation. Left eye was done first at the age of 3rd month, and right eye at the age of 5th month of the child. This child completed 15 years of follow-up with good or the transparent graft and good visual acuity. Here is a situation. Some patients in the long run will develop cataract. and you will have to tackle it. Cataract surgery with or without intraocular lens implantation in children with primary congenital glaucoma, or for that matter any pediatric glaucoma, developmental glaucoma, is challenging. And here is a situation where intraocular lens implantation was done in a child with primary congenital glaucoma. This recent publication from our institute, we talked about our results, 20 years results. 1128 eyes of 653 consecutive children with primary congenital glaucoma operated over a period of 21 years were analyzed. And we can see here the success rate decreased to almost 56% at the end of 10th year. Patients who presented with corneal edema or corneal scar did relatively poorer compared to the patients who presented with clear cornea. That is very well assumed because of the clinical situation. Here is a patient, moderate to severe degree of bilateral congenital glaucoma, operated at the age of 1 week, and the lady now completed about 28 years of follow-up. Here is a patient is from Bombay actually. We operated at the age of, in the year 1994, and completed almost 30 years of follow-up. So, in the overall management, comprehensive care of a child with congenital glaucoma, the first aim is to reduce intraocular pressure and to restore corneal clarity. And our final goal is to improve visual function so that the child develops good quality of life in the long run. The parents' condition, particularly the mother's quality of life in children with congenital glaucoma. We looked into the subject. We developed a novel questionnaire, congenital glaucoma caregivers questionnaire, quality of life questionnaire for the caregivers, a 20-item questionnaire, and it was, time is up, no problem. We have enough time here to discuss. We have time up to 20 minutes more, so no problem. We evaluated the quality of life of caregivers of children at preoperatively and then 6 to 8 weeks postoperatively. You see the quality of life has improved significantly. We looked at the quality of life of the afflicted children, and we realized that the results, our results showed that children treated with primary congenital glaucoma experience significantly better visual field and vision-related quality of life compared to other difficult glaucomas like secondary developmental glaucoma. This recent publication in the last year, we looked into the fact, the quality of life and life satisfaction in young children who are now adult. Our results suggest that the quality of life and life satisfaction of treated patients with primary congenital glaucoma during adult life are generally good and appears to be driven by factors other than clinical indices. Educational achievement appears to be linked to better quality of life and life satisfaction, and clinicians should always emphasize the importance and the need for education for the continued care during the continued care of these patients. This bar diagram talks about the employment profile of the afflicted children, and here is a subgroup of patients who are in the medical profession and other professions. Over the years, in 31 years, this is my 31st year in LB Prasad, 7 of my operated children are now MBBS doctors, of which 5 are doing post-graduation. 1 dermatology, 1 anesthesiology, 1 surgery, general surgery, and 1 anesthetist on pediatrician. They're doing very well. 5 PhD, 13 dentists, and several children are now teachers, engineers, lawyers, chartered accountants, and some of them are doing their own business, doing very well. This is the brighter side of this story. Some of the children with poorer vision are also doing very good because of the comprehensive management, because of the total care of the children, including medical, surgical, genetic, and rehabilitation approach. Rehabilitation of the children with poor vision or children who are blind needs care, education with the help of Braille system, and their career development should be encouraged and should be assisted. So what I was talking was the integrated approach for the management, integrating child's medical, surgical, and genetic and rehabilitation approach that gives the best chance of good quality of life and life satisfaction for the children and the afflicted family. These two photographs were taken in the year 1993. The parents here are with their first child who was born without any problem in pregnancy, and the child was having bilateral congenital glaucoma, mild to moderate form of the disease, and I was in the early phase of my development of career in L.V. Prasad Eye Institute. Whatever experience I had at L.V. Prasad with Professor Sood and 2-3 years experience at L.V. Prasad, I realized the child should be all right because of the milder form of affliction. In spite of my best attempt, I could not elicit smile on the parents' face. They are so afflicted with grief and depression. I took the permission, clicked the photograph at that time, and also took the permission that we'll present this thing in the different forum. They agreed. And I also said that after 2 months, when the surgery will be done, cornea will clear, the child will start taking fixation and look at you, you yourself will be convinced and you yourself will smile. That exactly had happened. After 2 months, while the child developed clear cornea and developed fixation, the parents in the waiting lounge here were smiling without any provocation. Just compare and contrast the two scenarios. I have had an opportunity to attend the marriage ceremony of that girl, which happened, I think, 3 or 4 years ago. The girl is now mother of a healthy child. Here is the child operated. The child is doing very well. The whole family is relocated to Canada. The child got married. I had the opportunity to attend the marriage ceremony of this child also. And they got the first child, normal. Second child, I am yet to see this child. They are in Canada. Second girl child, born on 3rd of November last year. They are yet to come. They promised that they will come in few months. They consulted locally. The child is perfectly healthy. With normal eye. I owe to Professor Sood for my experience of congenital glaucoma, learning experience at L.V. Prasad. After 3 years of MD, 3 years of senior residency with Professor N.N. Sood. When Dr. Patil was there, we used to work with Dr. Sood and used to do examination under anesthesia for all children he treated at that time, and used to learn the technique. This is a photograph of 89, 2010 in a meeting, and my last meeting with Professor Sood was in 15th of February in Gurgaon meeting, All India meeting 2020. I had an opportunity to visit him. Professor Sood and Mrs. Sood, unfortunately, both are not now living. They passed away. Professor Sood passed away on 14th of February this year. I owe to Professor Sood all my professional skill, for he is my Guruji with an unflinching stewardship, erudition and expertise, and an excellent human being. With this I